All right. Welcome back, everyone. I think we've had a great program so far. What do you think? Right? Thank you so much. It means so much to us. So we've heard about the incredible work being done at so many institutions around the world and supported by the foundation. We heard from them and learned from them, and so now our last session of this program is Q&A and what can we learn from each other. So our program was a little tight. We didn't have too much opportunity during the talks to ask questions, but this is your opportunity to ask questions that you may have, and I hope that we still have the speakers who gave those particular talks that you had questions on. So we'll try to navigate, and what I'll do is I'll read up these questions, which are the top priority ones people really wanted to know about. These are listed right on top, so I love this feature about this app. And we'll try to answer these and go down. All right, so I will read these questions out and try to find the person who can answer it best. If not, I can try to answer, and then Mike has graciously agreed to pass on the mic. All right, so the first question on top that everybody is wondering about is, can Tango 2 be progressive without a crisis? I feel this is $1 million question, and we will try to address that in our natural history study. From a small number of children who've had brain MRI at different time points, and it's a very small number. For some of them, we see some minor changes, but systematically we have not looked at the progression, for example, in brain of what really happens in these children who have really not had crises. But I would also like to ask Christina Miyake for her opinion about that.
Can you hear me?
Oh.
Want the microphone?
I think Seema, said it well in that we don't want to say anything that we're not 100% sure. We have small numbers of participants who are older in the study, but even today, just talking to Lisa, I'm hearing, and is it okay if I share a little bit? I do think that, when you listen to Tyler, he had a crisis early, so he doesn't really fit, but has kind of been on a smooth trajectory, and more recently is showing a little bit of decline. So I think with him, there's one other participant who's older who's also showing a little bit of decline. Neither are on full complex B, though. So there is another adult age participant who's not showing any decline, who's not had any crisis, who is on vitamins. So I think that's the $1 million question. If there is a decline, is it just going to be natural, or can we prevent it? And those are things, and if any of you have seen us, we're going around, we have a little form here. That's exactly what we're doing, is we're trying to assess that, see where you are now, and then follow you over time and see if there is a progression or a regression. So help us answer this question better at the next conference as we try to gather more information. So I think the short story is there might be, but we don't have enough data. If it is, it seems to be still pretty mild, even for subjects in their 30s. They are still doing well.
Thank you, Christina. The second question is, we saw where B5 looks very promising. Are there any thoughts around is more better or ideal dosing in general? Again, I can try to say a few words about that. So for at least from the natural history study, when Christina has asked families about this, it looks like the RDA, the recommended daily allowance, is what we are seeing. We are not recommending double or triple that dose. Correct, Christina, so far?
So we're not recommending actually anything because we don't 100% know, but we know that at a minimum you want RDA. So I have seen that if you're below the RDA, that might be a problem. But we don't know if you're triple or quadruple. You just want to be careful. B vitamins are water soluble, but if you're taking a multivitamin on top of a B complex and you're multiplying, let's say, vitamin A or something else, that some of these vitamins you don't want to overdose. So we have not necessarily seen a specific response with a specific dose, but guess what we're doing right now? So you bet what we're doing is collecting that data, so help us again. We're collecting that data now, and we're going to try to use objective measures to assess whether or not there's any correlation with the amount, what you're taking, and what particular vitamin you're taking. So for all of you to help us record what you're taking, if you can go back into your books, if you can remember what brand, what vitamins, and the amount that you're taking, and your child's weight, because I think we need to assess also by the size of your child and how much they're taking.
Right. And I'll just add a few sentences to that. So again, what Christina is saying, we have reached out to you multiple times over the last few months. Can you elaborate on that? Can you please help us explain that? So sorry about those multiple emails, but this is exactly the reason. Like, we want to be absolutely sure what vitamin, what dose children were taking before we could show all this to you here. So thank you for addressing that.
I do want to make a comment about vitamin B6. So if you are taking doses in excess of about 500 milligrams a day, that could be dangerous from a neurologic standpoint. You can get nerve damage from that. I have a different patient with a different genetic disorder who is taking up to 1,000 milligrams a day because there were case reports that B6 helped with her genetic condition. And so that could work. The nerve pain or the nerve damage that you can get could be manifested as worsened ataxia, so more wobbly gait, trouble with balance. So that's just something to be aware of.
Thank you. Kim.
So the vitamin specifically is vitamin B6. That can cause, it's called neuropathy. And in general, we have patients on about 100 to 200 milligrams per day, but definitely over 500 is too much. So just if you're taking multivitamins or supplementing a lot, just be aware of that.
Thank you. Okay, next question. Can people with Tango 2 have arrhythmia problems that are not connected to a metabolic crisis? I think I can also give my opinion, and of course Christina would need to chime in too, but it looks like from listening from Christina's talk, if you're not in crisis, you will not have arrhythmia that are not connected to, So I feel that arrhythmias are connected to a metabolic crisis. Is that correct? Can you develop arrhythmia without a metabolic crisis?
So we only have, when we looked, we have one patient who has what we call SVT outside of crisis. This is more of a common arrhythmia, probably occurs in about 1%. So I don't think that it's related to Tango 2, but again, we've only got 73 participants. But in terms, that SVT is not lethal. In terms of the arrhythmias that I talked about, the lethal, the ventricular tachycardia, you've heard torsade de pointe, that those terms we've only seen during crisis. For my patients, even though I know that you don't have an arrhythmia at baseline, I still check to make sure. And I like to know what your baseline number is. So PVCs are those single beats. I have some who have 0, and that's pretty common, but I have some who have a few beats, which is probably in the realm of normal. You should, if your cardiologist would know. But I like to know that because once you get admitted, if you get admitted, I want to know what your baseline is, so that if we're following you, 1 or 2 PVCs might be your norm. So I do want to establish that as a baseline so I know who you are. But again, in general, the answer is no, you don't develop the arrhythmias outside of crisis, the dangerous ones. One other comment with the vitamins, it's not unreasonable, like Dr. Houck said, we're putting this information out, this is new, but if you work with a nutritionist, a dietitian, your doctor, to make sure that as you are taking different vitamins, just to make sure you're not, that you're taking an appropriate amount, and you're not taking too much of certain vitamins. I would recommend that.
Okay, thank you. Next question, how can we become a part of the natural history studies? So I think in the meeting this time you had opportunities to meet Mashid, give samples, and if you still have to do that, she is here, Mashid. So you can stand up. So she is your main contact during this meeting, and she can enroll you in the study if you have not participated yet. She can help with biorepository, and then if you go home and you don't get a chance this time, you can always find us. So if you just Google Natural History Study Tango 2, she will pop up. So you can contact her.
Another comment, if you have friends or, other family members who work here and they're already enrolled in the natural history study, this new part that we're doing, you actually have to re-consent. So if you can reach out to your friends, we're going to try to reach out to them, but we need you to actually re-consent even if you've consented in the past. If you're new and you're consenting for the first time, you're on our appropriate consent that will allow you to do any of these.
Is that we sent you not so long ago, Seema? Is that, like, I know we had to answer a few more questions. Is that considered reconsenting?
Correct, yes. So the two things we added were adding the video taping and sharing of the videos with our experts, like typically movement disorder experts like Sam and his team. If you consent to that, so that's one addition. And then the second is this developmental assessment form that takes about 30 minutes or so. So that's what Christina has started doing for the reconsented families. Yeah. All right. Next question, are there incidents of individuals having a full genetic presentation but be asymptomatic? We don't have our son, non-symptomatic children tested, should we? Okay. So the question is, are there homozygous or two variant affected people who in Tango 2 who are completely asymptomatic? So as we know, we have one child who is 7 years old, and Giorgio's daughter, who appears to have almost nothing. Is that correct, Giorgio? Yes. So we know that she does have the same mutation as her brother, Eduardo. Other than her, we do not know of asymptomatic individuals with Tango 2. So I would love to have Carlota come over and then examine her and then test her. But hopefully this developmental testing that we are sending to all our patients can pick up something that we are not seeing. So we will know more, definitely.
Seema, there's actually, I don't know if they're still here. Are the Harrises still here? Did anyone get a chance to meet Seth Harris? Anyone meet him? I'm not sure you would know so much with him. He's got very good speech. He's fully, cognitively. So I asked his mom. He started B complex at 9 months. Carlotta started B complex at 10 months.
Yeah. So would you recommend, Christina, testing non-symptomatic siblings?
I think if you haven't taken any vitamins, the natural history suggests that that you have symptoms, but we don't know, right? This is what we're learning. So I think I would, until we know for sure. I'd rely on the geneticist, but particularly if you've given your child any vitamins, it's possible they might not have any symptoms.
Yes. So answer is yes, if you can do it. If your geneticist would agree to it, I would get them tested. Yes.
At a minimum, you'd know if they're a carrier, right? And you probably want to know that for future.
All right. Next one, does the emergency protocol on the website up to date with the research we have learned here? No. We have to update it, yes. Especially with Christina's paper that came out, the cardiac paper, and the natural history paper that we will be submitting soon. We have to update that. So that is the next thing we have to fix. Are there any medications all Tango 2 individuals are taking? If so, what are the benefits to them? Christina, I'll let you answer that.
I don't think there's any single medication that every single Tango 2 child is taking. There's a whole different, variety whether from GI to seizure meds to supplements to mitococktail variations. So I don't think there's a single one that is common. There's some that are not on anything.
Right. Next one is a good one. Is there any research completed on carriers of Tango2 and correlation with health conditions such as cardiac concerns? So there are very few autosomal recessive diseases, I would say, in which we know that carrier may have some effects. So Tango2, we have not looked at carriers in detail to know if they have any health concerns just by being a carrier. And these could be like late onset things that we are just not aware of. So I think more work needs to be done regarding that. Currently, we are not seeing anything that is being reported to us. So, yes, Sam.
So in the cancer literature, you'll see a lot of things in the omics space where they do these huge screens for genetic variants that might be associated with increased or decreased risk of different cancers. And Tango2 has popped up. Not that this should scare anybody, but as a minor modifier of cancer risk. I think the paper I'm remembering is prostate cancer, and there was another one in some other form. But this is not something that should keep you up at night. It's just, again, something that could be incidental, but also could be sort of interesting as we dive into the mechanism of this disease.
Right, and I would also add, and not knowing much about what you saw in the cancer database, but most of the time those are somatic mutations, which means that not germline, you were not born with that, you acquired it. So those are the somatic mutations we typically see for cancer. Question for Lena, very clear, straightforward here, Lena. So you talked about how you see an increase in the number of mitochondria in the cell for T2 cells under stress. Are there any other disorders like that?
I'm not sure actually if there is, but there are other genetic disorders where there are problems with mitochondrial fission and fusion. If you remember when I showed the increase in the number of mitochondria, yes, they are increased, but they are smaller in size. They are circular. There is problem with fission. That means they are dividing more than what there should be. There are genetic disorders with problems with fission and fusion. I don't recall that there might be. I can look it up, and I'm sure I will answer that question for you to see whether they looked at fission, fusion, and number of mitochondria and some other genetic disorders. That might give us insights also of others. So that's a good question. I don't have the complete answer for it.
I was just going to say one more thing. I was just talking to Dr. Gupta in the hallway. In the neuromuscular space, it's very common to see small fragmented mitochondria, and I think it's usually a kind of a secondary manifestation of the cells being unhappy or dysfunctional in some other way.
Yes.
So cells under stress will typically have that sort of fragmentation process occur as a byproduct or as a compensatory mechanism. And so when you look at those cells under a microscope, that is a fairly common finding, for example, in muscular dystrophies and myopathies.
Yes, I was about to say that. Because as a clinician, sometimes these patients would get muscle biopsy and prolonged hospitalization, and the mitochondria look really abnormal and exactly trying to compensate, and these are secondary problems that we see. The primary problem is different. So, yes, common for us to look at that pathology report.
And sometimes with the fragmentation, you can see different things. You can see population, so decreased, fragmented, and decreased number of mitochondria.
Yeah. Yes. All right. Okay, so Christina, this is for you. Can you share the history about Tango 2 deaths and why they died and maybe if we could have prevented it, if this is how I'm reading it?
Yeah, so there were 6 deaths that were related directly to the arrhythmias. In those cases, the medications were given and they weren't able to control the arrhythmias. In some cases, they don't have ECMO support. There's nothing else that they can do. And the patient's too unstable to try to get to another center at that point. Some refused, like I said, there was a couple that refused, that declined the ECMO support. And one who had neurologic injury because of the repeated arrhythmias. So despite going on to ECMO, they had to withdraw support. There were some cases in which arrhythmia wasn't involved, and I think those are the ones that we really need to better understand. And I think as more people recognize Tango 2, hopefully we'll get more information about those. All of those kids had some evidence, or most of them had some evidence that there was some cardiomyopathy or heart failure involved. Not that the heart failure was severe enough, but it may have been a combination of fluid overload early before they realized that the heart failure could be a part of it. In other words, rhabdomyolysis, or that elevated CK, the main treatment for it is to wash it out. So oftentimes you're going to increase the fluids, but if your heart is not happy and can't pump very well, and you give it a huge load of fluid, that can make the heart sicker. So it's possible that the combination of those two things could have contributed. There was one case in which the doctors reported that it was irreversible lactic acidosis. That's an elevated marker that your energy supply is, they're unable to get a good energy supply. It's hard to know exactly why the lactate's elevated in Tango 2 for sure, and why they couldn't reverse it. So there are still some unanswered questions. In some cases, they never checked the heart, so we don't know if there was a heart failure going on. But I think the vast majority that I read about is usually the arrhythmias that they can't control. And I think that for the ones where they couldn't control some of those cases, they did a last-ditch effort. And after giving multiple different types of medication, because you're trying so hard to get it under control and it won't stop. So at some point you give amiodarone. You know that you should never give amiodarone in a prolonged QT. It's given, and we had several of those cases that couldn't turn around. Now you also heard a French case where they gave amiodarone, and that kid didn't do poorly until 2 days later started to have more arrhythmias. Amiodarone, once you put it in the system, amiodarone's half-life, it'll be in your body for up to 9 months. So once you get it in, you can't get amio out, and that's important that your doctors, because they can't reverse that decision. So in general, I would say avoid it and go for the other medications. Does that kind of answer? I know it's kind of a...
Yeah, so it overlaps with the second question about Dr. DeLonglay's talk in management of crisis. Okay, can Christina elucidate on some of the treatment differences, if any, between her findings as they relate to cardiac crisis versus what Dr. DeLonglay discussed?
I mean, I think, to be honest, we're all trying to put together and put the information out as best as we can about what we see. I think the advantage to the natural history study is that there were 27 cases, and those were just the 27 cases that consented to be part of the study where I could collect their data. I didn't put in the natural history study, there were several cases, like I said, that call me in the middle of the night, whether you're from whatever country, and I'm trying to manage you over the phone. So they may or may, there's many that aren't in our natural history study. So I think in part some of my comments are based a bit more on direct experience with several different patients, and as well as the 27 in the study. And I know that there are some differences. We had some children who did get amiodarone, who didn't have a demise. So I think that each scenario can be a little bit different, but I'm trying to think specifically. Yeah, I think in my experience, and I didn't know if she meant beta blockers. So one of the things that Dr. Lalani said was to use beta blockers. And I'm not sure if she meant during an acute crisis or outside a crisis. I typically don't use it outside a crisis. During a crisis, what we found after multiple cases is that when the heart rate is low, when your heart rate slows down, you tend to have more of the arrhythmias. And like you saw, isoproterenol actually will increase your heart rate. Atrial pacing, which was another thing that we used that was successful, increases the heart rate. The folate studies that Dr. Zhang showed you increased the heart rate. We saw that higher heart rates tended to suppress the arrhythmias more. So for a couple reasons, I'm a little bit worried about giving a medication that I know hasn't worked for several different patients. Sometimes it can work, but it doesn't always. You can still progress on. But it also works. It can lower your blood sugar and it can lower your heart rate. I just don't think those are great combinations in particular for a Tango 2. For a long QT patient, yes, that's our mainstay medication. But I think we need to really think more specifically about this group of patients. And in my experience, it hasn't been the best drug to use.
All right. Thanks, Christy.
Dr. Lalani mentioned something about this.
Dr. Lalani did mention something. Oh, I'm going to introduce myself again. I'm Erica. I'm one of the research fellows at Baylor College of Medicine, but also a pediatric geneticist. So I can sort of comment on the metabolic portion of what Dr. Lalani mentioned. I think one of the first cases she talked about were intralipids, which are essentially fats that you can deliver through the blood. And she also mentioned carnitine. And I know Mr. Pochettino had asked that question in our mini session with Brandy, our nutritionist and dietitian. At least for those that have been in our natural history study, as well as the published cardiac paper, there have been people who've been taking carnitine, even at baseline at home. So I know she mentioned just hesitations in giving carnitine during an acute crisis, and I would say that there are children or adults with Tango 2 related disease, and they can have carnitine deficiency, and so they do take carnitine at baseline. Again, there are probably just differences because every child with Tango 2 related disease is going to be different, but I did want to make that as like a caution that maybe carnitine is needed for some of the patients who especially have deficiencies. And then regarding intralipids, I would say that some of the children that were in the cardiac paper especially, intralipids had been started. Total parenteral nutrition, which is nutrition through the blood instead of through the gut. That had been started early, and I don't know if it was the protein, the sugars, the intralipids that were in the TPN, but some physicians had even commented in some of the records that starting nutrition early, which included intralipids, had seemed to help. So I don't know if the intralipids in the case that Dr. Lalani mentioned were increased lipids or lipids only without the sugar and the protein. I'm not sure, but there are cases where TPN with intralipids were given, and it didn't seem to affect the arrhythmias or metabolic crisis. In fact, it may have helped. So just highlighting that difference, especially from a metabolic perspective.
Yeah.
Also on her contraindications, I think, was valproic acid. So if your child is already on valproic acid, I would say don't worry, you don't need to stop that medication. Actually, a lot of kids, almost I think 50% of our kids with seizures were on valproic acid. It's very helpful for myoclonic seizures, so a lot of our kids have those like jerk type seizures. Again, I'm not sure if it's in the acute setting, IV valproic acid, maybe that is contraindicated in a crisis, but if your child is on it at baseline, I would say don't don't worry about that. I think in general, valproic acid is avoided in mitochondrial disorders, but again, we have also a debate on whether or not mitochondria are dysfunctional in this condition.
Yeah. Sam, do you want to add to that? What valproic acid?
No, I would agree with that. I think, I don't know why it seems to work in Tango 2. I think it's really interesting. I've been trying to recruit David, and you can help on this project to figure out why, because I think it might give some clues to mechanism also. It does a lot of different things, has a lot of different mechanisms of action, including lipid handling. So I think that's also kind of a cool avenue.
And just wanted to add a few things about Erica. So Erica, this was her research year with us. So she spent hours, hundreds and hundreds of hours going through all the records that came through natural history studies. So I think she is the much more aware of the data that exists in these medical records besides Christina. So thank you for giving that opinion.
Totally ditto that. Erica was phenomenal. She got to know you. I think maybe in the beginning you were skeptical about the vitamins, but when you see it firsthand, just a couple of other things. Agree with the valproic acid. It's often contraindicated in mitochondrial diseases, and so maybe it's not the first line, but multiple parents have told me that they've seen a big difference in their children on it. So I wouldn't say it should be contraindicated in this. The other one little comment I also forgot was a comment about avoiding propofol and sevoflurane. These are two anesthetics that might worry you if you're undergoing anesthesia. Just wanted to comment, again, we need more data always to support any observation. So I'm giving you observational data. But at least in my patients and several, I actually got on my computer to actually look at the exact records. There is someone here, actually, a couple of people here who have, and I know they've done fine with Sevo, they've done fine with propofol. Looking at their lab values, they didn't bump with any of them. They had no arrhythmias. The one thing about having anesthesia, though, is you're often made NPO. If you know what I mean, you're made, you don't eat. If you're not aware of how important feeding is in Tango 2 and you're in the hospital, you might be that third case. You might be prolonged without any eating, and so as parents, that's really important. You don't want that to happen, and so that could push you or propel you into arrhythmias, and it might not always be the SIBO or the anesthesia itself. So those are things that we can do to be careful about.
Can you repeat the name of the medicine you were talking about? It's for seizures, right?
Yeah, valproic acid. Depakote, Depakine.
Valproix is another brand name. And also just a plug, if you are involved in the natural history study, please, I just want to stress the importance of sending us complete records as much as you can. There was a lot of information that we tried to gather and we just didn't have all of it. So even though we have 73 patients in our study, not everyone has every single data point. So I know it can be challenging to get those from your doctors, but we do appreciate them.
I want to add something. It's very important to me.
Thank you.
So I think it's very important also to differentiate between mitochondrial disease and mitochondrial dysfunction. They're totally very different. There are lots of genetic disorders with mitochondrial dysfunction, but this is not mitochondrial disease. There are mitochondrial diseases that they are more into the affect proteins that they are in the mitochondria complexes, the 5 complexes where at the end you generate the ATP. So those are mitochondrial diseases. So valproic acid is generally contraindicated in mitochondrial diseases, but the multiple other genetic disorders with mitochondrial dysfunction, it's not contraindicated. So these are two things, just a takeaway, I would say. These are very different things.
Thanks, Lena. All right, we'll move on. Are there any bad side effects from the medicines and supplements that are or aren't in clinical trials? While waiting for approval, can these be given? So, Christina, again, if you want to address the multivitamins and vitamin B complex. Who has the microphone? Lena, could you?
guess I'm a little bit confused. Maybe you guys can help me. Are you asking about the vitamins and supplements or other medications that are not approved? Or are you asking about clinical trials?
Is Cheryl here?
Are there any?
So maybe are there any side effects of vitamin B complex, for example, that we are recommending?
Right,
We
and
can
I
address
think
that.
Dr. Hauk did mention B6, and I do think that there's one other, I don't know if it's B3, but again, there are, if you take, there can be some, some side effects from overtaking certain B vitamins, so I do think that that's important. They are water soluble, so you should pee them out or urinate them out, but like Dr. Hauk said, we need to be careful. These are observations. Obviously, they seem very compelling, but it's still important that we do this safely.
All right. Gene therapy. Theoretically, how does that work? So, Sam? Yes.
So I'm going to plug the fall conference. So if that's still up on the website, there's a long video and you can watch all the talks. But the concept behind gene therapy is that you take a gene and the coding portion of that gene specifically, and it's called what's called a promoter, which is a little space of DNA before the gene that tells the gene to be expressed. And you package that within the shell of a virus, and we use a specific family of viruses called AAV, adeno-associated viruses, right now. And there's different types of adeno-associated viruses, and they go to different tissues. So for a disease like Tango 2, you'd obviously want a virus that goes to the brain and to muscle and to heart at a minimum. So probably an AAV9. So once you have your gene and your promoter, you stick those in a shell of AAV, and it would be infused intravenously one time. And there is a lot of hope for gene therapy. Christina mentioned SMA, which is FDA approved, and we use that. That's a condition that's now on the newborn screen, and kids get dosed with gene therapy shortly after that diagnosis is made. And there are several other diseases in clinical trials. So is that an adequate answer? Any lingering?
Yeah, I'm getting yes.
Yeah.
Yes.
So basically, you just let it do its work on the blood or in the blood like a virus, getting you infected.
Yeah, so the virus sort of works as a Trojan horse, right? So it gets the gene into the cell. Instead of spitting out its normal virus DNA, it spits out this new cargo that we've put in there. So it's, this construct, this Tango 2 construct. And it's important because it doesn't integrate into your DNA. It just kind of sits there. So it's actually kind of miraculous that it works as well as it does. And we don't have long-term data, but for SMA, we're approaching 10 years out, and those kids are doing really well. So we think it has multi-year effect at least.
And with every division of the cell, that's transferred to the new cells in the body as you grow in age? Or has to be readministered, or-
That's a good question. I don't think it would be, because it's episomal, so it's not part of the genome.
I can answer that because we are doing gene therapy on another disorder, and it does not divide and go into another cell. So you will have to give another dose again after like another year, depending on what is the level of protein in the body.
Theoretically, what kind of improvement would you see? Would you see learning, cognitive? Would you see just physical?
Well, yeah, so the hope, the question was what sort of improvement would you see? And I think the hope is that you have a full cure that's long-lasting, and there's a spectrum of outcomes from no effect to full cure. There's a lot of variables, so it's how much of the gene is inserted into, gets into all of the cells, so there's a delivery issue. There's a specificity issue with how good your virus is at getting to the tissues that you need it to get to. And then there's dosing, right? So how much virus are we giving? And you weigh that with the risk of side effects. So it's not a fully safe treatment because again, some of the gene therapy trials for myotubular myopathy, for example, they use, I think, a dose of 3 × 10 to the 14th, which is much higher. They had 2 kids die in that clinical trial. So I say this with some caution, packaged in that it's a very fast evolving field where people are really trying to optimize dose and think about tissue delivery and when is it safe to give it. Ideally, we want to give it as early as possible in most of these conditions before symptoms take effect.
So you're talking about the gene therapy, there's also like mRNA therapy, which is different that usually is injected once a month, and there are some genetic disorders that they are doing mRNA therapy for. But the mRNA therapy is injection once a month, and it's for the different genetic disorders. But that's also evolved at the same time with the DNA gene therapy.
There's a recording of it on our YouTube channel from the symposium back in the fall where Dr. McKenzie covers it. I can email it to you too.
All right. Next question, and I think this is also similar to Giorgio's question, so we'll cover that in one. Can families boost ATP production? This is at home through diet or supplements if the child is mildly sick and not in need of hospitalization and IV glucose. Yes. Do you want Mike?
So I didn't check that ATP vector yet. I really doubt it to have ATP packaged as a molecule to be delivered. I highly doubt it. But what I would say, we had a small group yesterday and we were talking. I think one of the important things is prevention. So if you know that your child is going to have activity, going outside, not even if it's not hot weather, just more activity than the usual, give them the extra snack before, give them these extra calories. This, I think, extra calories before having the activity, hydration is important. And once they're done, also you can, if they need extra, some little snack, you can give it to them. We do this with many of our metabolic disorders that we see, and we know that Tango 2 patients are prone to have hypoglycemia. And I think some of the families mentioned that they already doing this, and they do see improvement when they give them this extra snack before activities. So that's the prevention. And I think you mentioned if they are mildly sick, giving them the food they like that has more calories. I would say not only sugary stuff. Glucose is important, but also protein, because glucose will increase also their. You have ATP produced from glycolysis and from that mitochondria, but also protein can convert to glucose and can give you energy on longer term. Glucose usually is shorter term delivery for energy. Protein is longer term. So as much as you can give them things they like that have glucose, protein, a little bit of fat, but again, prevention is very important. Activities when they're sick, give them extra snack, hydrate them when they're back from being active, give them a little bit more snack. So.
All right, and I think that also covers this question of, are there any basic or specific nutrition guidelines for better health outcomes for Tango 2 patients? Correct? Do you want to add anything more, Lena, to that? ATP and this specific nutrition guidelines? For better health outcome?
I would say, always say I need evidence-based thing before giving guidelines. So for the Tango 2 patient that I'm following, at least I'll say the RDA, the recommended diet. So for protein, fat, carbohydrate, it's not like more or less of one. Having healthy nutrition, of course, is always helpful, but we don't have any evidence that giving more protein is more helpful than giving, more fat. So without having evidence for that and more data, I would not recommend having one more than the other. Having a balanced RDA.
Mm-hmm. Yeah. Thank you. All right, this is an interesting question. For each individual medical speaker, why are you so passionate about helping us families learn about Tango 2 by continual research and working towards a cure? Oh, I love this question, and I think everybody here may have maybe a similar answer or a slightly different answer, but we've been touched by you. I followed Sammy. Sammy was my patient, and that was my journey to Tango 2. So I will do anything that helps children get to better treatment, maybe cure one day. This is our mission. This is how we feel. We took care of these patients, so that's my motivation. And please jump in, speakers who talked about Tango 2, what's your motivation?
I can, yes, I only have one Tango 2 patient, but I got to meet many others during this conference, and I think that was unique. This is the first time I go to a foundation conference. I've been to many medical conferences. So there is definitely something unique in this, that you meet the families of patients that you're really working on research with, and that gives the research another meaning. But as a physician, any time that you make a progress toward better health or better outcome for your patients, that's really rewarding. I know from my kids, when they call me in the middle of the night of crisis, hyperammonemia, of ammonia of 800, and I come back and my kids, did you survive? And I said, yes. I said, yes, mommy. So it's so rewarding. So it makes you feel really good, and it's very rewarding work, I should say. It makes you feel good, and giving back to these patients and see improvement, it's definitely something I always look for.
All right, great. Anybody else? Sam, do you want to answer?
Anyone else?
Sure. I don't have an answer prepared, but I started honestly with the academic curiosity, and that's a very impersonal answer, but I think it's a puzzle. And so I feel like it engages both sides of my brain, the left analytical side and trying to figure out the mechanism and answer basic science questions, and then combining that with the emotional side and like Lena mentioned, and seeing how rewarding it is to actually have an impact on patients and families that are going through this. So for me, that's kind of the complete package of engagement. So
Thank you. All right. Moving on to next question. Do we have any information in the natural history study that would indicate what may be occurring during spells, even without lab abnormalities? I would say this is also $1 million question. We really need to figure this out. We see no lab abnormalities, but these are very abnormal movements, extreme fatigue that we are seeing, and we don't know why are they so episodic. Right now, our job mainly is to introduce the clinicians to this spell, the feature that we are calling spells, because they need to recognize it and think about Tango 2. Why these happen at a molecular level, I don't think we understand it yet. And again, anybody else wants to chime in for that?
I don't know. I mean, I wonder whether it's if it is an issue with energy source, for example, you are at the point where your body's able to compensate a bit. It has maybe the ability, but if you push it further, I wonder if you just run out, and that's at the point where your body starts to show those signs. I don't know. It's a good question, but that's what I kind of wonder. You're on that border. And if you can sleep, if you can replenish your energy source, feeding, sleeping, getting rest, then your body can get back its stores and compensate again and go back to normal. But if anyone has any other
And
ideas.
I think also Kim may want to say a few things about it.
Yeah, so from a neurologic perspective, there are a lot of disorders that are overall classified as paroxysmal dyskinesias, which is basically means episodes of abnormal movements. And these are often due to mutations in different ion channels. So we learned about in the heart how that's so important: sodium, potassium, calcium. There's some in other transport proteins. So I think by looking into that, we can maybe find some similarities and maybe find a connection on why this happens in this disease.
Thank you.
Yeah, and that's just another nice reminder. So that as part of the expansion and looking at development over time, we do want to go back and look at videos of kids with some of these episodes where you may have shown your pediatrician and they scratched their head and said, well, call me if it happens again. And we don't have a name for it because, again, I think the terminology is really critical when you can say, this is paroxysmal dyskinesia, or my kid had benign positional or torticollis, or segmental dystonia. Whatever the term is, it's going to ring some bells for clinicians and help with diagnosis and, again, maybe inform mechanism. So that'll be part of the natural history study, so don't delete those videos.
Thank you, Sam. All right, I think we can take two questions from Kasha together. They're both heart related. Can children have heart issues outside of metabolic crisis? That was answered. In cardiac crisis, will EKG and echo be in sync? Either both normal or both abnormal, or could one be abnormal and the other fine?
The answer is the last one. You can have one, the other, or both. You don't have to have them together.
Are you, so if there is prolonged QTC, I had this question, if there is prolonged QTC diagnosed in the ER, so you're recommending echocardiogram in the ER before you give them fluids so that you know?
I think you can start the fluids, but I think I would go ahead because oftentimes you're hypoglycemic, you want to get some fluids going. So I would go ahead and start the fluids, but I would get that echo going so you know whether or not, you have to be careful about the rate at which you're giving those fluids, because if your function is very low, you want to be careful about that. And if your function's low, they may need to put you in the ICU or somewhere else. So.
Thank you. What can we learn from carriers of Tango 2 disease? Do they suffer from similar deficiencies in energy production and heart defects? So, Patrick, I think we covered that in another question before that, so hopefully we can do this study at some point about carriers. Definitely, if as parent carriers you see something that we do not know and you feel that we should know, you are always free to reach out to us and ask us, do you see this in other people? So I think that way we will learn faster. Right. So Amanda had a few patients from UK, and she had mentioned that she was seeing the problems being mentioned on these children, and she wanted to bring these. Amanda, are you here? Right. So main things were a regression, as I understand, in these children without crisis and related to puberty. So I think these might be related to that question. How to improve Ellie's health when having her period. She's already on many pills, suffers from extreme tiredness and sickness. So this is the regression that I think you're hearing about. And then gets so tired, we really have to limit what she does. After school, she's barely awake. Worse, as she ages, she's 16. Can we help? So I don't have answer for this, but the question, and maybe Christina, you or Sam can answer, related to puberty, are you seeing regression? And this keeps coming again and again, like, is there, the first question was, is there progression of this disease? Do you have any thoughts?
I haven't, at least from what the interviews that I've conducted, and I have to tell you that the puberty issue came out, I want to say, yeah, so Oliver and brought it up. And so we didn't start asking those questions till kind of midway. We'd already done some of the interviews. And of the parents that I got to ask so they had to have teenagers, right? They had to go through puberty. I believe, if I remember them, 5 said yes, that they did see more worsening of more spell-like symptoms, more tiredness, more frequent episodes around puberty. But I've also had some parents say they saw nothing. So I think 3 said they saw nothing, 5 said they saw something. So I think there is something potentially, but not everybody. Here we were kind of making a little rounds, and it seemed like the girls seemed to be maybe doing better. Because we were wondering if the girls, so again, another question, but to answer this, we only have a number that have gone through or going through puberty right now. So it is on our question list now, but that's where we are. I haven't seen necessarily a particular regression per se. I've heard a lot of tiredness, these just episodes where they just seem to be having more spells. But you guys can tell me if you think that you've actually regressed in your... It's not regression, just more extreme lethargy. I keep hearing that. A lot of tiredness. The fatigue. That's what I hear. It's much more fatigue and tiredness.
Did Ryan have this?
Yes. Yeah, he told me.
Extreme fatigue was when he was 16, 17, and it's been better since the last 2 years.
So I think that question was how to help, because both of those girls are 16, one's 18, I think, and just extreme fatigue, especially around menstrual cycle, but
Well, finding the boy not girl, but in school anyway, we worked with the school to have him start later so he could get 10 to 12 hours of sleep a night before even going to school. And, I think the other thing was time. He's finally got growing. He's gonna grow. My theory is that in puberty, their bodies they need all that energy going into all that growth, and there's just not enough of it.
yeah. And I guess with girls is constant membership and impact, and if you don't make pregnancy, what impact that has on you, so support.
Yeah, that's okay.
You're all set.
But my daughter has a mitochondrial dysfunction, and she does take the pill, so it's so she has a mitochondrial dysfunction, and she took the pill to manage the energy impact. I mean, I noticed that it said they were already doing that, but does she take supplements too?
No,
Oh.
I've never even met them, I don't,
Oh, okay.
I don't know.
Because my daughter did both just to try to mitigate some of that, and it has helped. She's in college now, but it did help
Yeah, that's
some.
great. I mean, it might just be the pill that she's on, they might need to change the pill, I guess so.
All right, thank you. So Patrick, maybe you can ask this question much better than I can read it.
Patrick.
Let me see what I was thinking. So I just said, can all the mitochondrial compensatory mechanisms cause a problem if we conduct gene therapy to repair the variant? Golly, what was I thinking? I think we were watching, watching the video compensatory mechanism. Gene therapy. Yeah, I know what I was trying to say. Okay, so you've got all these mechanisms in the cell that have changed to compensate for all the energy that needs to be created, and you've got this dysfunction. What happens after gene therapy when we fix that? Are we looking at a possibility of overloading the body? I mean, is that a potential problem? If the body keeps doing the compensation and now we've fixed the dysfunction, like could that be catastrophic? I mean, could that kill cells? It popped into my head. I was curious about it.
Sam?
So I think one scary thing about, I'm throwing out the fears and doom here. One scary thing about gene therapy is that there is an inflammatory response that patients can have, even though the virus itself has been stripped down and is just a vector. So we often see elevated liver enzymes, for example, and we're watching for that in our current Duchenne phase 3 trial. So if we're thinking about viruses precipitating crisis, that in itself is a risk. And I think if I understand your question correctly, maybe Tango 2 is, or maybe in the absence of Tango 2, there's some compensatory mechanism that's taking place. And if we replace the Tango 2, are we now throwing off the body in the way that it's compensated? Is that accurate?
Yeah, it's just the mitochondria, the way they divide and they're doing the circulating. I mean,
Yeah, I don't know. I mean, certainly a good question, and I don't have an answer for that. Things I have thought about, if Tango 2 is kind of involved in some kind of homeostasis in the cell, so keeping things in balance, maybe it's not always turned on. Maybe the gene isn't always being read unless there's stress condition, right? So maybe at that point the DNA kind of gets activated and we generate more Tango 2 protein. So I have thought about that, because if you just use a generic promoter with your gene therapy, it's going to kind of be on maybe independent of these other things under native conditions that would activate transcription of the gene. So we probably do have to think about that, choosing the promoter and kind of the neighborhood, if you will, of making sure it turns on at the right times. But total speculation.
Right. So is there a general checklist of medicine or vitamins that is suggested? So we've covered that. I think right now we are just suggesting vitamin B complex, RDA. Next is what brand of vitamins are recommended. I don't have any preference, but if any family has had good experience with a particular brand, you can share. Okay, good.
Syndrome adult. And for a kid's vitamin, Flintstones did not have all the B's, so she said she recommended working with a dietitian to see if maybe the Flintstones plus the Mature or whatever.
Okay.
In combination with something might help.
You have to get the right Flintstones.
Yep.
So it depends on which one, that like the regular Flintstones doesn't, but Flintstones complete them.
Right, good. Is cardiac research manuscript available in full yet? Yes, it is. And should we carry it with our ER letter? So I definitely think that we should put the cardiac paper on our website, easy access for all families, and they can definitely take it with them to the ER. Yes. All right. Lily is here. Oh, thank you. Okay. IPS Petri dish cardiomyocytes showed electric abnormalities at baseline. Any idea why we do not see that in human patients?
It's hard to say they have arrhythmia at baseline. So when you culture cells, there are so many things that you can potentially change. So for example, one thing we found is you can grow cells at different densities. When they're sparse, they tend to have arrhythmias even at baseline. When they're more close together, they tend not to do that, which, in the native heart, cardiomyocytes are all packed together with lots of neighboring cells. So that could be one reason. But ultimately, cell culture is different from in vivo. That's why we're doing both research.
Right. Thank you. Some of these questions we've already covered, so I'll just keep going. Evidence for vitamin B complex. So you saw the evidence from the natural history study. We are really trying hard to have these data published so that once it's published, then that is what pediatricians would be looking at, clinicians would be looking at, published data. Yes. Thank you. And I really hope, because these are observational data and our reviewers can be very harsh at times and they might say, take that out. Everything else is fine, but the vitamin data is too observational. But we felt that it will save lives and it needs to be in the paper. And so let's see what happens. Krishna, you have to go?
Does anyone have any questions?
Let me just quickly.
I got you.
All right, we'll let you go. Thank you. Thank you. All right, we probably have 20 more minutes, and so let me just keep going. Next question is, do you know how old Hannah is, Amanda? She's 9. So she's 9. She eats every 2 hours. She gets grumpy, fatigued. Is it common to need feeding this often? She has a tube. Okay. So yes, our kids need to eat frequently, and this is what I've seen. Every 2 to 3 hours they snack. Is that what you would say too? Right. So this is something that we see often. Okay. All right. Yeah. So sympathectomy. She mentioned it in her talk, and we covered that. We covered the exhaustion. Right. We covered that we need to know more about this regression if it's really happening. You are absolutely right, Patrick. Benchmarks on this journey can be difficult. Is it related to 1% better talk that you mentioned? Yes.
Yeah.
Yeah.
Sometimes you have to keep going.
Right.
And you check in later and you find that, it stuck. The effort paid off. She was getting it. You can't look day to day sometimes because you'll get very discouraged.
Yes. Anybody wants to make any comment about that? Yes, Jamie.
I'd just say that I had a therapist when Oliver was younger, and they gave me really good advice. They just said, compare Oliver to Oliver, and stop trying to compare to typical peers or even other special needs kids, because we didn't have a model at that time. We didn't know, of course, Tango too, but I thought that was kind of helpful to get out of my own head about, trying to compare and the typical milestones and things.
All right. From Sam, More broadly related to autosomal recessive inheritance pattern, carriers, does the medical community have hypotheses regarding presentation in carriers? So